Our next topic is pain management in polytrauma patients. Pain is the fifth vital sign in healthcare system. Pain in trauma has a role similar to the double-edged sword. On the one hand, pain is a good indicator to determine the severity and type of injury. On the other hand, pain can induce severe complications like hypoventilation, reduced oxygen, increased stress response, increased cardiac output, and increased muscle tone and rigidity. It may lead to further deterioration of the patient. Therefore, knowing how to manage pain in trauma patient is an important part of systemic approach in trauma. The ultimate aim of pain management in trauma is reducing the mortality and morbidity. To clear our concepts, I would like to call eminent pain consultant Dr. Varsha Kurhade Madam, and I would also like to call Dr. Kalpana Kulkarni Madam, Professor in Anesthesiology, RCSM Government Medical College, Special Interest and Fellowship in Pain Management, past President ISA Kolhapur, to chair this session. I would also like to call Dr. Tippanawar as a co-chair, who has done fellowship in pain medicine, fellowship in musculoskeletal USG, started his own pain clinic, has been invited for national and international conferences. I request Dr. Kalpana Kulkarni Madam to introduce our speaker.
Good afternoon, everyone. After the post-lunch session, this is second lecture by Dr. Varsha Kurhade. I am happy to introduce her. She is Director and Program Head, PENEX and KK Multispeciality Hospital, R&D, Pune, Head of Pain and Palliative Care, Indrayani Hospital, KK Multispeciality Hospital, R&D. She is also running, looking after this all hospitals as a director. She is Secretary of Society of Pain, Pune branch, co-editor, EC member, Society of Anesthesiologists, Pimpri Chinchwad branch, editor of Spandan, IMA, Pune, awarded fellowship by Indian Academy of Pain Medicine, FIAPM, and she is integrated pain medicine certificate course she has done, interventional pain management fellowship from Daradiya Pain Clinic, Kolkata. She has been accredited fellowship in palliative medicine from Cipla Cancer Institute, Pune. She has published more than 10 research papers, and she is also faculty at state and national level. She is a very young, dynamic pain physician. Now let us listen from her how to manage pain. After all these management since morning, setting up the pain trauma centers, triaging the patient, giving blood components, stabilizing the patients, and then referring to all these on-arrival blocks and surgical part. Now patient is having pain. So how to manage pain? Let us listen from Dr. Varsha.
Thank you so much, madam, for this generous introduction. And I would like to thank ISA Sangli Miraj branch to invite me, especially Dr. Vasudha Jadhav ma'am, to introduce this topic of pain management for polytrauma patient, which I call it as poly, that is multimodal pain management as well, just like trauma. So now, before starting my topic, I would like to awaken everyone. Awaken in the sense, not from post-lunch session, especially when the inauguration session was going on and sir mentioned about Dr. Lomte, and he was one of the dedicated pain practitioner in this area. So pain branch, I really feel privileged to be a pain practitioner and relieving patients' pains. So this lecture I would like to dedicate to Dr. Lomte, and it is not only loss for his family, but for the patients, especially practicing in this part of the state, peripheral, where there are not much of a pain practitioners and resources. So this is the work, pain work, which is carried out in this part of your district by Dr. Vasudha Jadhav, Dr. Kulkarni, Dr. Tippanawar, Dr. Lomte, and it's a great service to humanity. So I would like to invite more people into this branch, being dedicated pain practitioner, seeing ups and downs, and whatever it takes to establish yourself as a pain practitioner. So any one of you who's willing can approach me anytime. And now I will actually start with the topic. Just to add, when sir mentioned about the transport minister is in his contact, sir. So I remember this one point. This automobile industry sells on the basis of how, great their vehicle is trauma proof, and those are crash test and everything. So that is of course to their USP or to have their TRPs. I remember this one point, my son's school bus, they are all sealed at the 45 kilometers per hour speed. So if you can put that one more suggestion, that sealing the speed, that might add to this agenda. Okay, so how I will proceed with this talk? Roadmap, magnitude and spectrum, a lot has been talked since morning. Overview of this topic of polytrauma, pain physiology, pain assessment, interdisciplinary team approach, pain management, continuum care, barriers in pain management, summary. So prevalence of pain in trauma patient. We have been seeing statistics of trauma, but when it comes to statistics of pain, it is huge. 91% patients with trauma, obviously it's acute pain, present to the ED with pain. Up to 15% trauma patients receive inadequate analgesia, and the mean time of getting pain relief is 60 to 90 minutes after the event. Someone suffering from crucial pain since 60 to 90 minutes is like another, experience of facing imminent death. That's what we say. Older patients are 12% less likely to be given pain medication than younger because of their physiology and all other factors. As many as 2/3 of trauma patients leave ED without their pain being adequately controlled. Like there are many places pain teams are available. I was just speaking to Dr. Kotwani, Sion Hospital. There is dedicated pain team. So they are taking good care of pain. But 2/3 of trauma patients, it's a significant number. So spectrum of injuries, we are all aware, maximum are head injuries, probably that's the reason sir mentioned that people run to neurosurgeons the moment they come across trauma, followed by abdominal injuries and facial injuries. So mode of injury and number of patients getting injured, two-wheeler accident followed by car accident are the majority injuries we face in polytrauma or otherwise road traffic accident. The significant thing to notice here is average time taken to reach ER from the site of injury. If you see this pie of circle shown in brown, 1 to 6 hour, and golden hour, that is that teal green color, is less than 1 hour. So very few patients reach to the ER services within golden hour. Now coming to pain in polytrauma. Any trauma is painful, obvious, but untreated or inadequately treated pain intensifies the effect of trauma on respiration, hemodynamic stability, renal, GI function. We have been speaking about blood transfusion and products like crystalloid, colloid. But inadequately treated pain adds to every burden on the hemodynamic system. And the treatment of acute pain is also essential to facilitate recovery from trauma by enabling early mobilization and avoiding all these complications. And not to forget, in our practice, chronic pain practice, poorly treated acute pain can cause disabling chronic pain syndromes like post-surgical pain syndrome, CRPS, and so on. Pain physiology. Coming to this technical part, IASP, International Association for Study of Pain, proposed revised definition of pain recently, 2020. It is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So this sounds really confusing. The whole point of stating this definition is pain is not only physical or physiological damage. It is sensory as well as emotional experience. So pain is a multidimensional emotional and sensory experience, and patients' reporting can vary based on physiological, psychological and contextual factors. For example, severe crucial pain is the alarming sign for patient to be the imminent death sign. Like patients are okay if they are diagnosed with the cancer, metastatic cancer, that's fine. But why my back is hurting? There is metastatic vertebra. They are least bothered about their cancer. But the moment they get pain, they feel this is the sign of death and this is the threat to their survival. So same is the experience in trauma patient. And that's why even when the anatomic stimulus is constant, cognitive processing makes pain perception as a dynamic process. So pain pathway, we have all learned about it. Just a quick revision. transduction, transmission, perception and modulation. These are the components of pain pathway. And these are the etiological or dimensional, which we call it as pain palette, multidimensional pain, which has the factors right from genetic, body structure and function, comorbidities, physical, lifestyle, social, emotional and cognitive. Even if it is acute pain in trauma patient, these factors do play the role in patient's experience of getting intense pain. Assessment of pain. Multidimensional nature of pain is to be considered while applying these assessment tools. In this, we have to take into account patient's cognition and communication ability, which is not there in most of the trauma patient. Like in the morning, sir mentioned, patient is yelling in the pain. So definitely that's not the urgent case to be handled, even if patient is calling you. And reassessment of pain systematically using the same appropriate tool and re-evaluation is what is the key. Pain assessment is a complex process and pain is a difficult to fully quantify even with any single assessment tool. So now this is the pain assessment tool, and what comes in a way of pain assessment is, it is always subjective assessment. I tell to the patient, there is no blood test or there is no scan which can tell me, okay, there is this much of pain. So pain is a subjective symptom and you have to really get exactly what is this. Like there might be patient who is crying, yelling, even at the score of numerical rating scale 4. And there could be patients with the pain scale of 8, but they are smiling and telling, हाँ थोडंसं दुखतं इथे, जास्त काही त्रास नाही. So this is how it is very much individual experience. And this is triage pain ruler. Of course, in patients of trauma, the shock or the psychological effect of having undergone accident or trauma is much more than real physical pain. So you really need to have that thin fine line while assessing pain before putting any analgesic, especially opioids. So this is the triage pain ruler. You will get it online anywhere. And there are so many scales, just not to miss anything, I have listed them. It is practically impossible to cover in any one lecture. So unidimensional assessment tools for cognitively intact patient who can speak to you, who can read the scales like numerical rating scale, visual analog scale, defense and veterans pain rating scale. Then there are assessment tools for patient with cognitive impairment, but they are adults, like behavioral pain scale, critical care pain observation tool, functional pain assessment tools, KAPA and FPS. So these are the tools. If you see this colored scale, it has got numerical rating part on the upper side, 0 to 10. 0 is no pain, 10 is the worst possible pain. Like when I ask the patient, the words are, हात इतका दुखतो ना की खांद्यापासून छाटून टाकावा वाटतो, किंवा पाय असं दुखतो ना गुडघ्याच्या खाली पाय कापून टाकावा वाटतो. This is what is pain scale 10. So the expressions are different, wordings are different. This is how we have to gauge the scale. So from 0 to 10, then there is a color scale, and then there are emojis. So this is one very useful scale applicable in most of the range of patients. Now pain assessment, behavioral pain scale, facial expressions, upper lip movements and compliance with mechanical ventilation. And these are the scoring system. These are very much technical scales. Critical care pain observation tool, again in the critical care area, emergency, ICUs, where patient can't vocalize or can't express how they are feeling. Assessment of pain, coming to severe dementia, pain aid scale, the functional pain scale, Dolo +2, pediatric pain assessment. We are all aware of FACES pain scale while managing post-op pediatric pain, color analog scale, pain assessment tool for children like FLAG, FACES, leg activity, and similar scales. Pain aid scale, again I have just put the table for everyone. The moment you have the visual impression, at least डोक्यात तरी असतं की हां एवढ्या गोष्टी आहेत, and we go and search for it whenever we need to. So now again this is FLAG scale, Wong-Baker FACES pain rating scale. Now caveats in pain assessment, like I already mentioned to you, on a scale of 0 to 10, how would you rate your pain? And when I ask this patient, समटाईम्स आपल्याला आपल्या लोकल लँग्वेजमध्ये जसं की थोडे गावाकडचे पेशंट असतात, 1 रुपयामध्ये किती दुखतं, शून्य म्हणजे काहीच नाही आणि 1 रुपया म्हणजे टेरिबल पेन, की तुम्हाला काहीच सुधरत नाही, जीव गेला तरी चालेल पण दुखणं नको असं वाटतं. सो दॅट इज वेन आय आज देम 1 रुपयामध्ये किती दुखतं, 4 आणे दुखतं, 8 आणे दुखतं. सो दिस इज हाऊ दे इंटरप्रिट इन डिफरंट वेज. So unless I get to know कि okay, this is consistent with my assessment, I keep asking in different various forms because all pain scales are subjective and there is wide variation between individuals. Age, sex, ethnicity can affect pain perception, and especially when it comes to trauma, it is really challenging. We all know, of course, polytrauma as it is a team approach. Trauma surgeon, thoracic surgeon, all surgical branches, and radiologist as well as anesthetist along with emergency physician makes it much easier and in terms of outcome of the patient. So what should be the goals of pain management? When it comes to polytrauma, we are really walking on the thin rope when we have to do pain management, because the moment patient loses consciousness, we don't know it's because of pain relief, because of opioid, because of respiratory depression, or he is collapsing, his hemodynamic system is shutting down. So it's really skillful job when it comes to pain management in trauma patient. Early initiation of appropriate treatment, aggressive use of multimodal therapy, treatment of the underlying cause, like if there is a fracture femur and we know that splinting the leg is the first line treatment to control his pain, stabilize the fracture, reduce the blood loss, and then comes the actual pain management techniques which might not be even required the moment we splint the femur. Assessment and management of psychological factors, the biggest part and the least addressed part in pain management. Stepwise approach, pre-hospital management, early management in ED, thorough assessment of increasing analgesic need. As we re-evaluate, reassess ongoing trauma, we have to assess similarly for pain. Pain management for surgery, pain management in ward, and continuous pain medication devices like catheters, pumps. So management of acute pain symptom. Acute pain symptom is obviously related to trauma in this respect. We have to acknowledge pain, validate and empathize with the patient's pain. Like most of the time patient is literally, आपण म्हणतो ना, कणहत आणि विवळत येतात तिथे, आणि ॲज अ डॉक्टर लाईक दिस इज डेली सिनॅरिओ फॉर अस. पण द मोमेंट पेशंट इज ऑन टेबल आणि तिथे सिस्टर काहीतरी ट्रे आणून ठेवते, आपण काहीतरी करत असतो, बिझी असतो, अरे थांब ना, एवढा काय ओरडतोय, थांब जरा मला ड्रेसिंग करू दे. And that itself is a painful experience for the patient. That he has suffered from the accident. He is really getting that excruciating pain which was never before. So empathizing with the patient is the first step. That itself reduces the pain to 50%. Believe me, practice this and you will experience this. Then pain assessment, within 15 minutes evaluate and respond to pain driving symptomatology. Pain relieved, very good. Inadequate pain relief, of course we have non-pharmacological pain management, distraction techniques, heat, cold, splinting. Reassess pain, every 15 minutes reassess pain. If it is really excruciating pain, you can introduce pharmacological methods, very good, depending on pain score, and continue to implement non-pharmacological methods as well. Sometimes just relative being with them, वी आर लाईक की नाही हे असं आत हॉस्पिटलमध्ये येत आहे. ऑफकोर्स ओ टीमध्ये तर आपण नाही अलाव करत, बट समटाईम्स इन EMS वेन द एमर्जन्सी थिंग्स आर सेटल्ड डाऊन, जस्ट अलाविंग सम रिलेटिव्ह, let my wife be in, let my son be in, that makes hell lot of difference in everything, even in patient's compliance to your treatment if someone close by is with them. Reassess pain every 15 minutes, NRS, VAS score, hemodynamics. Okay, WHO ladder. Being anesthetist, we have been exposed to this right from our first posting, and it starts from mild analgesic with mild pain to strong opioids for severe pain. And it has been updated with 4th step, especially to add interventional pain management, which is pain specialist domain, to address very severe pain. Okay. So though there has been controversies regarding its application or relevance in different types of pain like acute pain, cancer pain, chronic benign pain, it still holds the place, basic WHO ladder I am talking about, in professionally managing the pain. Pre-hospital analgesia. Many patients have been given some form of pain relief before reaching the hospital, depending on the skills and experience of pre-hospital staff and local protocols. So the moment patient is with you, please check what has been given, if at all patient was in ambulance or accompanied by some medical team. Morphine is the first line analgesic even for major trauma. This is again controversial part, being respiratory depressant and all. Many people don't prefer this, but abroad morphine is 10 milligrams pre-hospital dose is very standard. Entonox, we know the combination for moderate pain. If the pre-hospital team has a physician, I have inquired this with many reputed hospitals ambulance team. If they have physician, or forget about pain physician, at least nurse, we always call pain nurse. In my hospital, I have trained some staff who is dedicated for pain. So they know how to administer these drugs under the instruction and supervision, and what is to be monitored once you administer the drug. So this kind of staff, if they are available with these emergency trauma ambulances, they can take care of these medication, including ketamine, as I have mentioned, unlikely in Indian scenario. Oral medication, paracetamol, NSAIDs, codeine can be easily administered. Early pain management in emergency department. Again, morphine intravenous is a gold standard. Of course, we have to dilute 10 milligram morphine in 10 ml of distilled water or NS, and every 10 minutes, 1 ml, titrating the doses and assessing the response. Ketamine, very useful adjunct, subclinical dose. We all use it left and right. We are expert in, you all guys are expert in that than me. 0.1 to 0.3 milligram kg, suboptimal dose. Shorter acting opioids, fentanyl, alfentanil, remifentanil, available mainly at institutional or corporate levels. And basically being anesthetist, we are really blessed to handle these drugs with lot of expertise and titrate them based on the patient's response. So even if, like sir asked madam, how many centers has trauma unit in nearby area? So those who are really working with good setup with resources, I would request that you should jump in whenever there is trauma setup, trauma cases, jump in and offer these services to have maximum outcome. Pain management on arrival block. We had a complete topic dedicated to this, and this is simplified by Jana sir for me. So these may be performed for specific conditions as detailed below by the trained personnel with fully monitoring and under sterile conditions. So basically these have definitely proved better, or in fact best in trauma management for two reasons. When we give parenteral analgesic or any systemic analgesic, compared to that, on arrival block or regional anesthesia doesn't affect the remaining hemodynamic part. For example, for femur or for fracture rib, just putting intercostal nerve block or ESPN for chest trauma, your other systems are not going to be shut down because of parenteral analgesic. So this is come long way. And second thing, if at all you have to take patient to the operation theatre, you can continue the same and just add a little bit, say TIVA or some another regional technique and supplement this to continue in the intraoperative period. So just the examples: femoral nerve block, fascia iliaca, brachial, interscalene, intercostal, and reassess pain scores at regular interval and top up as needed. These are few examples of on arrival block. You can see the landmark technique. I have purposefully put these pictures. This is landmark technique, this is USG guided block, and this is actual under sterile preparation, how you perform the block. Surgical option, surgical fixation of fractures itself aids pain relief. Anesthetic options depending on experience of the individual anesthetist. Sometimes some are comfortable using continuous opioid infusion, some are expert in putting peripheral blocks. So like sir had also mentioned, it's not like what is best or what is preferred over other. It's the technique which you are acquainted with, which will help the patient in that particular scenario. So pain management in operation theatres, you can see this is intercostal nerve block under CAM guidance. I started USG guided since last 3 years only. I didn't have machine. So I have been doing this since 10 years, USG guided, CAM guided intercostal nerve blocks, okay. With the dye, once you put the dye and you get the satisfactory spread, you know you are at safe space. You are neither in the lung, you are nor in the vessel. This is ESPN block under CM. USG guided is the gold standard right now, but you should not be stopped just because I don't have USG, okay? Pain management in operation theatres, central neuraxial blocks, epidural catheter, we are all expert in this. Most likely to be used for second stage surgery and reconstruction, because epidural, you all know, it takes time to put the epidural and to get the action as well. So it is not in emergency most of the time. Paravertebral blocks for chest wall trauma, wound infusion catheters, mostly like upper limb or lower limb amputations, initial bolus, these can be titrated as per need. Okay, again, pump infusions. If you have syringe pump, good. Otherwise, you can use this elastomeric pump systems for continuous infusions. So this is the diagram where it's a kind of a summary of pain management. These are all the options available for pain management as per the pain pathways, right from transduction to perception and modulation, okay? So at the site of trauma, local analgesic, anti-inflammatory drug, then regional analgesic, gabapentinoid, gating agents, different regional blocks, then alpha agonist, NMDA antagonist, and SNRI. Non-pharmacological pain management. Very, very, very promising technique without side effects and easily applicable without needing expert staff or expertise, okay? Of course, cognitive strategies, CBT and all needs training, but it can be easily made available in the resource poor setups. Cognitive behavioral therapy, hypnosis, mindfulness, music therapy, virtual reality. You all know ना, छोटासा मुलगा खात नसेल तर त्याला मोबाईल हातात दिला की सगळं जातं. Pediatricianचं वॅक्सिनेशनचं रुटीन हे झालेलं आहे. So this is all because of these things. You distract them, you have these therapies in place. Physical strategies, acupuncture, aromatherapy, iontophoresis, immobilization, massage therapy. Of course, in polytrauma patient, these come at a later stage, okay? And this is the study where I could find evidence base in trauma or burn care, moderate to high evidence only for music therapy and virtual reality. This is something really promising, and to look at the same aspect from some different angle and introduce these therapies in management. So again, coming to pharmacological pain management, reverse pain ladder. We have seen WHO ladder, mild, moderate, severe, very severe. And now in trauma patient, because pain is maximal at the beginning, so this is the principle. In trauma patient, we can have reverse pain ladder applied. Patient control analgesia pumps, swapping from patient control to oral control, titration of oral opiates. These are all fine-tuning methods required. And of course, giving laxative and antiemetic. Otherwise, especially with steroids or blocks, like neuraxial blocks, patient might have constipation, bloating, and these flatulence. These add to their pain, and we keep scratching on our head what is wrong in abdomen. So it could be just simple medication like laxative, antiemetic, and patient is relieved. Other pharmacological treatment, like gabapentin, pregabalin, amitriptyline, in trauma patient, once the very acute phase settles down, what we need is anxiolysis and patient sleeping quietly. Of course, when you don't have fear that if it is, because of hemodynamic instability, some ongoing blood loss or respiratory depression, it is just that he has got pain relief and he is sleeping. That's the stage. You can introduce this medicine to relieve the anxiety to get good, calm sleep. Analgesia in polytrauma, A, B, C, D, E. This slide has been covered in detail by previous speakers very well. Barriers to pain management, like I already said, fear of masking injuries. In polytrauma case, pain is a good sign. Pain is a welcome sign, because whenever patient complains pain, we are alarmed that yes, something is going wrong. So here, while doing pain management, of course, we are feared of masking injuries or ongoing damage. Fear of impacting hemodynamic status. Fear of respiratory compromise. Lower priority compared to resuscitation and stabilization. But as I said, pain has a detrimental physiological effect on every system. So definitely, this should be the take-home message, that priority, just because there is blood loss happening, pain need not be addressed, should not be the point of view while treating this pain. Underuse of effective analgesic technique, Lack of pain protocol or order sets, another important reason. Lack of pain management knowledge by providers. 40 to 60% of trauma patients have other substances present on admission like alcohol, street drugs, prescription medication, strong opioids and all that should be kept in mind. Factors associated with the development of persistent pain after trauma. Now here onwards starts the chronic pain, which is my specialty. So what are the factors? These factors are going to take patients over the period of months or years into persistent chronic pain, like younger age, multiple surgeries, poorly managed acute pain. So as an anesthetist, we always keep on stressing peri-operative pain management is something which will give patient not only operative or post-surgical pain relief, but lifelong pain relief. Okay. Duration of disability, that is time to return to work. Earlier, faster the return to work, less is the pain. And of course, psychological factors add to that. So this is post-traumatic stress disorder classification to combat the pain. Acute pain to chronic pain, as you can see how it proceeds. I just mentioned about the same. Transition to chronic pain via unremitting acute pain. So this is all the spectrum from which patient experiences chronic pain. PTSD, breakthrough pain, pain associated with prolonged tissue healing and surgical revision. Like trauma patient keeps coming repeated surgeries over the period of weeks and months. So this is the graph where we say pain management across the trauma care continuum, like continued pain management is required. Of course, in pre-hospital region, mainly they are non-pharmacological or simple medication. Emergency departments, it is opioids and more systemic adjuvants. ICU care phase, of course, again these medications to be titrated. Trauma ward and discharge follow-up, the graph comes down. This is the summary of the whole topic which I spoke about as per the phase of care and multimodal strategies. Take home message, like you can see in this picture, finally the Superman is grounded, and that's the good news. So the context was the last lecture discussion. We really need to be grounded at a time and look at what is required. Being empathetic with the patient is what matters the most. These are the few references for my topic. And thank you for the patient listening. As you have been listening about this National Annual Pain Conference, 40th Pain Conference, just like ATCON, we have ISSPCon, Indian Society for Study of Pain 2024. It's happening in Pune after 20 years. So I request every one of you to register for this conference and enjoy the feast at Pune from 2nd to 4th February. First will be the workshop. As a Secretary of Pune Pain Society, I appeal all of you to come and enjoy our hospitality. Thank you so much.
Thank you, Dr. Varsha. It was a very well covered topic from acute to chronic pain. And in acute pain, one should make efforts to control the pain by polypharmacy. People do for it, but it is a optimum analgesia should be given to prevent the chronic pain, because 30% of patients do come with a persistent post-operative pain, and even though it is a mild to moderate, but one should treat it accordingly at the source, that is an acute management.
Right, at the source. Perfect.
Any questions?
Thank you, Varsha, for your nice elaboration about the pain assessment and all management program. But I have one question, being pain physician, to you. Some patients, like following trauma, they may undergo amputation.
Right.
Amputation of the upper limb or lower limb. So these patients are very resistant to any kind of pain modality for relieving the pain. So how you manage, have you come across such cases? Post-amputations or stump pain or chronic CRPS pain, which develops later on after discharge over a period of months or weeks or up to a year, they come with severe pain. So that requires definitely some aggressive management.
Yeah, as I mentioned, madam, chronic phantom limb pain and chronic post-surgical pain. Maybe it may be scar pain or it is just like abdominal pain, continued pain. So these are the very common entities which can be really addressed well during anesthesia. That's why I stress on these two topics in all, our anesthesia talks, because we are dealing in acute phase with these cases. So first I would like to address as an anesthetist and then as a pain physician.
No, regarding stump pain or
Yeah,
phantom
stump pain, that's what-
So they
that's
come
what.
later on with pain.
Right,
So how
right.
you manage for that chronic pain?
Right, I got that, madam. So during anesthesia also, we have to have regional anesthesia modalities, not only for surgery, post-op care as well. Like my father-in-law had traumatic amputation below knee 5 years ago during the accident, and I had put catheter for 1 month, epidural catheter. During that period, he underwent 5 surgeries, repeated revision of the flap, then flap didn't work, then trauma, okay? And after 1 month of epidural, when it was removed and he came for dressing was hardly anything, and he had tremendous pain. And then the surgeon said, "Madam, your pain relief was so excellent that he is not even tolerating dressing. This should not be done." So my message here is, if you manage that acute post-traumatic phase intensely, they don't develop phantom limb pain or stump pain. And when they develop stump pain, now coming to your question, when patient comes to us, we first start on these medication called as neuropathic pain medication, which are simple anticonvulsant, SNRI, SSNRI, and sometimes, very few times, opioids. Okay, if they don't respond, 50% of the time they do respond very well to this medicine, along with supplementary cause. Most of the time it is muscle which we have to address, myofascial pain component. It is arising from some other component, and we think it is stump pain. So stump pain and phantom limb pain, these are two different entities. You are asking about stump pain which is existing. Okay, so stump pain very well addressed by regional blocks. You can just put the catheter above knee or below knee. You can put femoral catheter or your this saphenous nerve block. They work very well, regional technique. And if that doesn't work, we have infusions, lignocaine and ketamine low dose infusion given over the period of 1 week in a titrated dose. That works very
Have
well.
you tried sympathetic blocks for this?
Sympathetic blocks for these cases, diagnostic can be given, but they doesn't work that well for these cases. If diagnostic works, you can go for alcohol neurolysis or radiofrequency ablation, but not these cases, phantom limb or stump pain.
Okay, thank you. Any other questions from the audience, or you can ask some? With this, I also thank the
Which epidural
organizers
catheter still
for
putting, madam?
giving me this
Madam, you
opportunity.
told
to share
epidural
this.
catheter you kept it for 1 month.
Yes.
Did you change or how it was?
I changed it. I changed it every week. I had tunneled it subcutaneously. Like I said, I work in a cancer institute where we have a lot of cancer patients, abdominal cancers, and we have to give epidural infusion. I don't have that system of PCA and which costs in lakhs. And patient goes home, they don't stay with me. So I tunnel the catheter subcutaneously. Same to his needle, give adequate local infiltration. You put the needle in the subcut region, wherever it comes, catheter comes out through skin puncture, thread it, and little bit laterally. Okay, just like intrathecal pumps. But those systems are very costly. And then elastomeric pump, you put the pump doesn't last for more than 5 to 7 days. And you have to give adequate analgesia and antibiotic cover. And that works. And there are catheters like chemoport, which goes for 2 years, 3 years. Okay, they are costly.
Thank you, madam, for your wonderful talk.
Thank you.
I request Dr. Kalpana Kulkarni, madam, to felicitate Dr. Varsha Kurhade, madam. I request Dr. Shivannawar, madam, to felicitate Dr. Kulkarni, madam. I request Dr. Hanuman Jadhav, sir, to felicitate Dr. Tippanawar.